Basically what I want to say is, in what are the conditions when you can safely needle, what are the conditions where needle is unsafe, and what are the dangers when you don't do needle correctly, judiciously. Again, dry needling is a kind of treatment which we don't learn in our schools, as in physiotherapy schools. We take it outside. It's still not a part of our regular curriculum. So we may need to be a little judicious, or we may need to understand needling, and that is one of the purpose of this particular course called as Dry Needling 360. This is the second day of the course. If you are here for the first time, yesterday we had a lecture where we had just introduced dry needling and we had said what is dry needling. Now today we will go about the safety features of dry needling, if we can put it in that way. So how does it work? You take these classes either in real time, that is in YouTube live, or you can come back and you can take this. After this, you take the MCQ. Beforehand, we had circulated in the WhatsApp groups the pre-reading material or study material, whatever you say. And after you watch this in the WhatsApp group, I circulate a quiz, and you take the quiz. In the quiz form itself, there is a download certificate, so you download the certificate automatically. Now, there was an issue yesterday with downloading of certificate, downloading of quiz, because I guess my website is a basic simple GoDaddy website. I think it was get a website based upon WordPress platform. Why am I saying this is? It probably has a shared server. I'm not a technical guy, so the website took a lot of time to generate the certificates, and many of my respondents are yet to get the certificate. So please don't panic. The certificate, the page of certificate, the quiz will stay forever as long as I have the website. So if not today, you can always have it tomorrow. Right, so this is the process. Go through the study material or pre-reading, attend the lecture on YouTube, attend the quiz in the given link, download the certificate, and then after you have attended all 6 lectures, I'll give you a longer MCQ, probably a little more tough, and after that you can download the course completion certificate. So if you see these steps, the first 1, 2, 3 steps can be jumbled. The 4th and 5th step has to be taken in order. So if you're first day today, if you're attending the lecture on YouTube, there is no particular order. Although I would strongly recommend going through the first lecture if you're here watching live, then after this class, and then you can again follow any order as long as you are completing the course. Yesterday we had talked about the introduction of dry needling. Today we are talking about the safety features of dry needling. Tomorrow we'll talk about myophagia, the amazing myophagia. Day after tomorrow we'll talk about how analgesia is produced with needle, and we'll talk about the physiological effects. How is it going to work? What are the reasons why it works? Then we will talk on 20th May about the needle manipulation. How do you manipulate the needle? Why do you manipulate the needle? Is there any scientific explanation, or you just want to fiddle with the needle? And then the last day we'll talk about standardizing the delivery, standardizing the care of dry needling. Coming back to today's class, we're going to talk about indications, contraindications, and dangers of dry needling. Now, when we think of indication, if you have gone through a formal PT class in India, you must have studied modalities like, say, TENS, and then you must have got a list of 1, 2, 3, 4, 5, 6, 7, 8 conditions. For example, this picture shows that this particular modality is being used for neck pain, back pain as a whole, low back pain, front of abdominal pain, and this and that. So I don't want to give boxes like that. When you think of dry needling is a specialized care, and as such you must understand that you must know what are the physiological effects, what are the therapeutic benefits of dry needling, and if your clinical condition fits those therapeutic drawbacks, then you can supplement it, you can treat that condition with those facilities. So do not have a laundry list or a bucket list kind of that and try to match the following. That is a very UG way of thinking about dry needling or about any form of treatment as a whole. So that this is what I mean to say, that when used purposefully, dry needling works in multiple conditions. The condition is endless, so do not limit yourself to a say range of conditions, and they work in musculoskeletal, neurological, and neuromuscular conditions. So now, so what are the therapeutic effects? One of the major purpose of dry needle, one of the sure shot benefit of dry needle is analgesia. Someone is having pain, you needle the person with proper dosimetry, judging the proper structures, that is assessing the proper structures, the person is going to get good analgesia. Sometimes you may need to supplement, as in attach TENS, but otherwise the patient is going to get great quality of analgesia. So analgesia of any type can be, analgesia coming from like pain of any type can be treated with dry needling. Then resolution of trigger point, as we had discussed yesterday, trigger point is the origin of dry needling. The epicenter of origin of dry needling was trigger point. And then you can promote healing by working on the modulating the myofascia, the fibroblast, including increasing local blood supply, etc. We'll probably discuss this a little tomorrow, a lot when we are talking about needle manipulation. Then the therapeutic effects are also improved muscle length and joint range of motion. Now you can ask why or how dry needling can produce increased muscle range or increased joint range of motion. How it works is, again, it works on the myofascia. Myofascia, the facial fibers, are modulated via the use of the needle. We'll discuss this more tomorrow. And then modulation of fascia, which I call it as myofascial modulation, it restores the tensegrity. It also reduces the spasticity by restoring length-tension relationship. If you are more interested in spasticity, then you can look into the work of Pablo Herrera of Italy. He has done a fabulous job of working on spasticity. Yesterday also we had talked. He has copyrighted the technique called dry needling for hypertonicity and spasticity, DNHS. So if those are the therapeutic effects, the suggested indications can be, again, trigger points of any kind, pain of any origin. So as a primary or secondary analgesic modality. What do I mean by primary analgesic modality is, if the patient comes to you with pain, you can treat the patient and reduce the patient's pain only with dry needling. But in many cases, patients are already taking certain amount of treatment, other kinds of treatment. What are the other kinds of treatment the patients are taking? For example, if someone, a patient is having metastatic cancer, maybe the patient is taking heavy analgesics, sometimes opioids. Now, dry needling has been proven to be an adjunct to opioid analgesic and has been proven to have some benefit. Then you have pain of multiple other origins, muscular pain, muscle spasm, acute spinal pain. You can use dry needling. Then there are so many other indications. I have repeated the slide, sorry for that. Now, if still you want that laundry list, then I'm not giving this list of condition. This condition is being given by American Physical Therapy Association. So they have given a long list. Of course, the list is not exhaustive. So you do not try to match your patient's condition with that list and then only you needle. But they have given a wide enough range of conditions, and I'm going to pick up, again, cherry pick some of them in the successive slides. So as you can see, the first slide here shows scar tissue. Scar tissue has a lot of collagen which are not aligned. You can align the collagens using dry needle. Then you can see this is a myofascial problem. These are facial fibers. APT as mentioned, contracture, joint contracture or taut band. Then back pain out of discogenic origin. You can also treat radiculopathy, the second picture, joint degenerative conditions, joint dysfunction is the word APT has used, tendinosis. So all your tennis elbow, golfer's elbow, Achilles tendon issue, patella tendon issue, all the tendinosis, basically many of the soft tissue conditions, you name it, say from shin splint to say patella tendinosis to tennis elbow to plantar fasciitis. A lot of these conditions are either primarily as the main treatment modality or as an adjunct. Dry needling can treat them successfully. Then migraine and tension type headache is one of the indications. Again, I'm not saying, APTA is saying. Next, carpal tunnel syndrome and all other computer desk job related conditions can be treated successfully with dry needle. Pelvic pains, phantom limb, and then night cramps are some of the other conditions that APTA has mentioned. Of course, APTA list is a longer one and also not exhaustive. But you understand that these are conditions where pain is present, these are conditions also where trigger point is present, these are conditions where also there's a problem, mechanical problem in the myofascia, and again there are conditions where nerve is affected. So all these are indications of dry needling. Again, the dosimetry, the duration of treatment, number of sessions the patient require will vary from condition to condition, person to person, and structure involved, and sometimes it does not cure. For example, chronic osteoarthritis, you cannot reverse the chronic osteoarthritis, not with any sort of treatment, but you can take away the pain of the patient, take away the suffering of the patient for significant amount of time with dry needle. So if I give you an example, say I am a 50-year-old person and I have gone to a festival shopping in the shopping mall. I know that I have osteoarthritis of my knee and I manage it with exercises and certain other things. Now because I have stood there unaccustomedly in 6 hours, next 2 3 4 days I'll have increased amount of pain in my knee. That pain can be taken away and put the patient into baseline where there is no resting pain, where there is pain only in certain situations where you are taxing the body, can be achieved. Okay, so that is in certain conditions. In other conditions, if there is trigger point, say you wake up in the morning and you are looking at one side and you cannot turn the neck on the other side, dry needling is one of the modalities which can treat this successfully. Again, if I have tennis elbow, then dry needling is, if my patient has tennis elbow, dry needling is something that I will use on my first session. So there are multiple conditions, there are multiple benefits of dry needling and indications. You should not limit yourself to the laundry wrist. You should be looking at what are the therapeutic effects you are trying to achieve, and if you get those conditions or get those uh, target list, problem list, then you should implement dry needling. However, what is most important here, more important is contraindications. In what are the conditions you will not use needle? Now, before I go into the description of the condition, we must understand when we say contraindication, there are multiple types of contraindication. You can actually plot them into a 2 by 2 table. You have absolute contraindication where you should never use dry needling, and then you have relative contraindication where with a little bit of precaution you can probably use dry needling. Also, there are general contraindication and local contraindication. So what do you mean by general contraindication? General contraindication means if that condition is present in our body, in the patient's body, you should not use needle at all. On the other hand, if you have a local contraindication, for example, open wound will always be a local contraindication. So if I have an open wound in one part of my body, on one limb, the other limb is fit to be needle. So with that understanding of contraindication, let me just describe 1, 2, 3, 4 contraindications. And again, this list is not something that I am proposing. This has been given by American Physical Therapy Association. APT has a fantastic resource paper on dry needling. So if you are interested, go back, search it. It is free of cost. It is available on the website. So first, let us think about absolute general contraindication. So these are basically common sense. Just to refresh, absolute general contraindication means if these conditions are present, you are not going to needle the patient ever. In a patient with needle phobia, unwilling patient is unable to give consent, the patient has problem with communication, the patient has cognitive issue, uh, the patient has history of untoward reaction of needling or injection in the past. Some people, rare few, have stainless steel allergy, and our needles are made up of stainless steel. So in such a situation, you are not going to needle the patient. In my 10 years of needling and teaching needles, I have seen only one person who had reacted to the needles, and I have used good quality needle, whatever the needle that is available based in the market. And then he had developed those specific, those uh, allergic eruptions throughout the body. So then, other common sense is medical emergency. If a person is having a heart attack, you're not going to needle him, right? So these are all common sense, general. Now let us talk about absolute local contraindication. This is something that you must remember. If a patient has anticoagulant therapy or any other kind of condition where the patient is having problem with bleeding or clotting, then you should not needle the person too deep. Because if I have, say, a problem in my shoulder and you have performed a superficial dry needling on my shoulder, there's some issue with the bleeding and you are on the, say, on the deltoid, you can just use the compression or icing or something as a hemostasis. However, if you have needled a deep structure, something like a psoas or tibialis posterior, then what tends to happen is, if you cannot compress and stop the blood, the person will keep on bleeding internally, which will produce problems. So again, this is an absolute local contraindication. And lymphedema is another condition where the patient is having lymphedema. In that particular lymphedematous limb, you are not supposed to needle, because then what will happen is, if you insert the needle, you pull out, you create a small wound. Now normally when you have that wound, the wound helps, the wound promotes healing response, but there is no healing here. The healing process is meddled with, compromised, so there is chance of infection. And then if you have seen the latest stages of lymphedema, they are almost always infected, so you are adding to the patient's pathology. And that is why, if the patient has lymphedema, then you are not supposed to needle the patient. And nowadays a lot of patients are coming after radical mastectomy or partial mastectomy and coming out of cancer, and because the survival rate is so better nowadays with treatment, we see in our clinic, in our OPD, a lot of the patients have patients present. Now in those patients, because they are always in pain and the weight of the limb and all, we may be tempted to needle them, but never do that. Try to avoid that. Now coming to the relative contraindication, I have put them in order, so you can see A, B, C, D, E, F, V, I, P. A and B is abnormal bleeding tendency. Now we have already talked about abnormal bleeding tendency once, where we have talked about thrombocytopenia. But now many of our patients nowadays are into blood thinners. What in our country, what we get is called as ecosprin. So low dose aspirin is that we something that a lot of patients take regularly as a part of their regular medication. Excuse me. So in those patients, you must ask what is the dosage, and it is best to talk to their physicians or surgeons who have prescribed that medication, take them on board. Sometimes what happens, the surgeon or the physician says, okay, I'll stop the medication for 2 to 3 days, you do whatever you want to do, then we'll start it back again. It's a very safe way to go. If, however, the referring physician or the person who treats this patient for his uh, other problems, cardiovascular problem, they're not happy or they're jittery, please don't needle the person, because if something bad happens, then it will be on your shoulder. Then compromised immune system. So people who are either on immune suppressant, for example, after a lot of say abdominal surgery or say removal of uterus. After that, many times to prevent adhesion, the surgeons prescribe to the patients high dose of steroid. Now, in that case, if the patient is having immune suppression, the other example will be cancer patient after chemotherapy, or even better is, or even a stronger example is organ transplant. The person has to remain on say immunosuppressants for rest of his life. So again, what is the problem? Where is the problem? What is the kind of solution you're proposing? All this uh, will be will have to be taken care of before you needle the patient. Diabetes. Now, my country, India, as of now, is called as the diabetes capital of the world, and some statistics say that out of all the adults, one third of them are either diabetic or pre-diabetic. So, how do you do you not needle them? Now, understand this is a relative contraindication. So, if you have to needle a diabetic patient, you will have to ask one question to yourself, and the question you should ask is, what is the risk? The risk here is two. One, the most obvious is, if you have created a wound on the patient's body with your needle, will it heal in time? If it does not heal in time, two things happen: the area will keep on stretching, and second thing is the area will become infected. And the second thing is that particular area anesthetic? Because again, anesthetic part of the body, if you injure, you know the sequel. So if the patient is, so the thumb rule is, if the patient is healthy enough to take an injection, probably the patient is healthy enough to take a needle. Only a patient who is having uncontrolled diabetes will have enough contraindication not to needle him. Again, coming to epilepsy. In case of epilepsy, the problem is, once you insert the needle, the stimulation of the needle may start a seizure for the patient. So if the patient is having enough stability under medication or run of the mill petit mal grand mal epilepsy, no problem. Patient is taking medication, go ahead and needle. If you have an iota of doubt, talk to the neurologist of the patient. Take his consent. Next is frail patients. Because our aim of needling is to promote body's own analgesic system, body's own healing system, body's own way to take care of itself. If the body is not at its optimum, how needling is going to help? The needling is going to produce more damage. So in frail patients also, you are not supposed to needle. Vascular diseases, if the patient has peripheral vascular diseases, the patient has say a varicose vein, again, you don't want to needle on those areas. You want to find an area which is free of vascular disease, otherwise it is a relative local contraindication. Infection, local contraindication of pregnancy. Pregnancy is a matter of debate. Now, when you want to needle a pregnant patient, what is the purpose of needle? A lot of things needs to be understood before you poke a pregnant lady with a needle. The major problem a pregnant lady suffers from is related to the posture, and you cannot give a long-term solution of analgesia also related to, like, in the posture, because the posture is basically a physiological deviation. So you may be able to give the patient some temporary analgesia, but then you have so many other ways to do that. Why am I saying is because pregnancy is an emotional issue, and if statistics are to be believed, 1 in 3 up to 30% of the conceptions are naturally terminated. So suppose you have been a very judicious proper needler and you have treated the patient with all the precautions, and then also the lady comes to know that the termination of pregnancy happens. Many times it is very difficult for us to convince the patient in that state of mind that it was not my fault, or it was basically not anybody's fault, it was nature. Another thing is, needle in itself does very little. A lot of needles benefit are related to how it stimulates the receptors. And if you study pregnancy, the process of pregnancy means the body goes into a complete overhaul of the receptor system. So you do not really know how far the the stimulation you are giving. Maybe you are hoping for a little bit of stimulation and you are giving so much of stimulation that the patient's childbirth process starts. So as a thumb rule, avoid needling in the first trimester. Do not needle also in the third trimester, and in the second trimester be judicious. Avoid needling around the abdomen at least. So that is about pregnancy. Now along with pregnancy, the thing that comes here is lactation. Again, with needling there is a lot of release of endorphin which goes throughout the circulation and probably is released in the mother's milk. So unless you have a very strong reason to needle say patient, a lactating mother, avoid. What is also not mentioned here is needling the children. Many people I have seen in Facebook also have needle kids who are as young as 1.5 year old. I feel that is unnecessary unless you have a very strong compelling reason. Multiple reasons for giving this argument. First of all, below 12 years our anatomy is completely different. So if you are needling a kid who is younger than 12 years, you should be knowing the anatomy very very thoroughly. Number one. Number two, younger kids, their body is so soft and subtle. If your aim is to modulate the myofascia, you can do it with a gentler method as well. Very importantly, as I was discussing yesterday also, the whole world in form of physiotherapy is going towards functional training, functional rehabilitation, functional exercise, functional activity. So in many cases, our aim is to reduce the pain, to harmonize the muscles, to homogenize the structures, and then get functional movement. Because if the person is in pain, the person has trigger point, the person has mechanical disorder, the normal movement sequence will not happen. So in many cases, dry needling is a precursor so that you can come back to function early. Now I am yet to see a kid below 12 years who takes the needle happily and ready to cooperate after the needling session to do functional activity or exercise. For most of us, when you see a kid, when a kid sees you with that white lab coat, he starts crying. And we physios, we tell them, no, I'm not going to give you injection like the other doctors. And now you come with a needle. The trust factor is very difficult to re-establish. So apart from this list, lactation and children would be other relative contraindications. Now coming to dangers, the most important part of the discussion today. Dangers are the conditions which dry needling, if not applied correctly, can produce to the patient, or iatrogenic condition. Now, when you say dry needling is dangerous, you should not think of it as something that is definitely going to damage the patient, because we are doing something invasive with the patient. As a physiotherapist, I do very little invasive thing. In the ICU, probably the suction and that kind of stuff in OPD basis, dry needle. So because we don't do it every day, we may have a little bit of apprehension. The risks of this is a little different from risk of other manual therapy or other therapeutic interventions. But that is not exclusive. These dangers are not exclusive to dry needling. We all have heard stories where a physiotherapist tried to manipulate the neck of a patient, or an untrained professional, untrained non-professional, sorry, has tried to manipulate the spine and the patient has ended up with paraplegia, quadriplegia, and even death. Similarly, I remember with my first-hand experience as being the model of one of my seniors in exam, and that person has created periosteal burn in my lateral epicondyle. So what I mean to say here is, don't get daunted by looking at these dangers, but please be careful with them. Be judicious. And the major problem, the real life-threatening problem that needle can create is pneumothorax. Pneumothorax, as we know, is air in the pleural cavity, and because the pleura has a negative pressure, that is why the diaphragm is able to work, diaphragm is able to descend, and the negative pressure builds up and the lungs flare up, lungs get filled. So if you introduce air in the pleural cavity, or if you introduce a communication with the exterior using the dry needle, effectively what we are doing is we are changing the pressure gradient, and the lung is going to get trouble. The lung is going to be non-functional. Now let us see how this happens. The typical case, this was actually a patient who had been needled by one of my student, and the student had actually produced pneumothorax in this patient. And so this is a real life case, real life scenario. Then the typical case is a 52 years old ectomorphic male smoker who was needled in the left upper trapezius for neck pain in sitting position. The therapist inserted a 60mm needle in sitting position. Then the patient started to develop pain and breathing difficulty in the evening, 6 hours after the session, mind you, not immediately. This is important because many times the pneumothorax happens after a few hours, after half a day after the session. Pain is around the neck and shoulder, and the typical hallmark is it increases with inspiration. Now, understand this. When we think of pneumothorax, we think of a picture like this, what is there on your screen, where the affected lung gets shrunk. But luckily, the pleura also has multiple folds and septums and everything, so it kind of can stop the pneumothorax from happening unless it is a massive injury. So if the pneumothorax is a small one, the digital x-rays are inconclusive. Only CT scan will reveal pneumothorax in the affected area. So this is the typical case. What is the incidence? Iatrogenic pneumothorax happens in 5 to 7 per 1000 hospital administration, 10,000 hospital admission. And then in case of dry needling though, it happens 1 in 10,000. I apologize for the absence of 10,000 digit in the blue box. So in dry needling, the numbers are pretty high. If I have to give you an example, say a box of needle that we buy has 100 needles in it. So if you in your lifetime have used 100 boxes of needle, then you may have statistically produced one pneumothorax in the patient. Good thing is, not all pneumothoraxes are symptomatic. If you have seen a chest tap, a pleural tap biopsy, you would see if you go to say a high volume hospital, many times the pulmonologist will just insert the thick big needle, take out the pus, and then apply a simple leucoplast and nothing will happen. However, those things happen in the lower lobe. The upper lobes are much more exposed to air, so there is more chance of having pneumothorax when you're needling the upper part. Now, what are the clinical features? The clinical features are there in your screen, but as you can see the difference in the color, if the patient has a sudden and sharp chest pain and breathing difficulty, Do not wait for the other clinical features to flare up. Immediately you take that patient to a hospital where there are two facilities. One is a digital chest X-ray. As I said, digital chest X-rays not always are conclusive, but if the needling induced pneumothorax is massive enough, then you will get to know. And the other facility that is necessary is intercostal drainage tube. But for our patient, the typical case or the case study that I have shown, all you need is a rest. So 3 to 4 days of rest. Initially, what happens? The first day the patient does not have too much of pain. In the evening only the pain comes, and then what happens is over a next couple of days the pain increases, and then slowly the pain subsides. Majority of the pain happens because of deep breathing. If you take a deep breath, the pain will increase, and you'll get those very characteristic sound in auscultation while the patient breathes. So to avoid pneumothorax, what is most important here is patient selection, because we all know the anatomy that if you want to avoid pleura, medial one third of the clavicle, just one like up to 2 inch above the medial one third of the clavicle, you have the pleura. Then lateral border of the sacrospinal is the area you have a safe needling zone in spine. But then, if the patient is having abnormal anatomy, like this picture, you do not know where the pleura ends, where the lateral border of the sacrospinal is, if it matches. And this is true not only for pneumothorax, anywhere else in the body also. If your patient has a condition where there is malunion or a congenital deformity, be double cautious, because we are not into anatomy, we are into pathoanatomy now. Be cautious, very cautious while inserting the needle there. Then people who are tall, people who are thin. I'm getting a lot of questions here. Sound is low. All right, I'll try to shout, or I'll try to come a little more closer. So in patients who are tall and thin, especially teenagers, they have a higher risk of spontaneous pneumothorax, so be careful with them. And with people with severe spinal deformity, right. And next is, don't be a Rambo. Do not say inject, or do not insert needle on the patient's body mindlessly and hope that the patient's health is going to be all right. Patient's uh, symptoms will be taken care of. Target the specific area where you want to go, and go only where you want to go. Do not go into an area which are uncharted territory. A few more things: if you want to needle, say, a structure that is uh, close to pleura, and a structure that is an anti-gravity muscle, a postural structure, then do not needle in erect position. Needle that particular patient in either standing position, in lying position, in a position where the patient takes rest. The other ways that you can tackle needling with or prevent pneumothorax with is by using certain techniques. For example, protection of bone. So if you are trying to needle the pectoralis major, you try to put the needle in the above the rib. Similarly, if you are trying to needle the supraspinatus, let me get the angle correct, try to insert the needle into the supraspinous fossa, so you are getting the shield of the bone. Same thing with infraspinatus, and same thing with rhomboids. Do not go between the ribs, needle over the rib. There are specific techniques to ensure them. But they have to be learned hands-on. So bone protection we have discussed. The angle of needle is also important. We'll discuss the angle of needle even more when we do a safety and standardization webinar or lecture on the last day. Then, but basically if you go oblique, you are going to control the amount of depth, if I insert this needle, let's say this is a needle, vertically, you can reach far deeper, whereas if you go oblique, then you stay within the area or gap. Then pull out the tissue away from the rib cage, and all the while control the depth. So these are the way to avoid pneumothorax. Now when we think about bone protection, हर्ष, ये लाश कहाँ से आया आपके पास? आपका तो नहीं है, right? So if you use bone protection, please understand that the membranous bones sometimes do not ossify very well. We all have seen this in our anatomy labs, where the scapula, sometimes even the ilium, do not completely ossify. So control the depth. It's not that you understand or you hope that there is a bone that is going to stop you and go on pushing the needle. On the other hand, where there is membrane, you may have pierced that bone or protection. That should not happen. So please understand, the bone protection has its own limit. Then injury to the blood vessel. Now normally a needle is so thin it cannot injure the blood vessel very well. As in, we are inserting needle in the blood vessels continuously, no? We all know that the diameter of our dry needling or acupuncture needle is very small. In the accompanying picture, as you can see, I have inserted an acupuncture needle into the eye of the sieving needle. So it's so thin. If you go back to the textbook, you will see that IV cannula is about 3 millimeter in diameter. On the other hand, our this needle are 0.25 millimeter in diameter, sometimes 0.15 also. But why do you want to damage unnecessarily? And then if the patients are having some sort of problem, say related to clotting, you don't want to trigger that, and especially in the areas which are more susceptible. For example, around the carotid, around the jugular, which are very close to your heart, you don't want to damage there. So it is very important for you to palpate the pulses and to avoid needling that area. More often, what tends to happen is you have inserted the needle in a body part and there is some superficial vein. So if you take out the needle, when you take out the needle, there is a black bruise in that area, usually. Now that is not something very serious unless there is a significant amount of hematoma that needs medical attention. And in that case of bruise, what you do with say IV, a bruise left by an IV channel, you do the same thing. You ask the patient to apply thrombophobe. Nerve injury. There are real cases of irreversible nerve injury produced by dry needling. So unless you are sure of what you are doing, you must avoid inserting the needle into a nerve. There are specific techniques of neural needling, but unless you have learned needling under supervision of a quality dry needling therapist, instructor, stay away from the nerves. Now, understand this. The diameter of the needle is 0.25 millimeter, but the largest of the nerve fibers are even much more smaller than the thin needle. If you see the A alpha, the thickest of the axons are about 20 microns thick. So if your needle is like your fist, so big, your A alpha, the thickest of the nerve fibers will be like a strand of the hair. I cannot show you an example of hair because I don't have it. But imagine this: if this is the needle, this is the nerve. So this cannot go inside this. Difficult. What tends to happen is the nerves are not in isolation. There are bundles of nerves which forms a fascicle. So your needle can go between the two fascicles and can produce local compression, which may produce neuropraxia. And if you have manipulated the needle after you have inserted the nerve, after you have inserted the needle on the nerve, then you had it. It's like you have inserted uh, a knife into a, say, bowl of soft uh, chow mein noodles. What will happen is the knife will definitely cut the the threads of chow mein. In this case, the nerve. So there is irreversible injury. And specific areas that one needs to be taking care of is the foramen magnum area, the posterior suboccipital area, and the brainstem part. So these are the areas where you have to be extra careful to prevent nerve injury. Organs is a lot of common sense. Unless I wouldn't say you, but the therapist is really dumb. Nobody is going to insert the needle into the stomach or liver or intestine. So that is why the angles are important, the depths are important, and to have the sense of purpose of why you want to needle, where you want to needle, and how you want to needle is very, very, very important. The others, the other dangers are minor dangers: stuck needle, bent needle, broken needle. What do you mean by stuck needle? Once you have inserted the needle doesn't want to come up. So that is, again, if you give enough time, the needle will come. Bent needle happen because of two major reasons. One is therapist's fault, another is patient's fault. What do you mean by therapist's fault? Once you have inserted the needle may have hit a roadblock, say a bone. After that also you have pushed the needle. That would be therapist's fault. What do you mean by patient's fault? Once you have inserted the needle, the patient has given a strong contraction. In a muscular interface, if the patient has given a strong contraction, the needle will bend. But unless the needle is of poor quality, the needle is not going to break usually. So if you have a broken needle, it is not your fault, it is the manufacturer's fault. Or it can be your fault if you have reused the needle, re-sterilized the needle and reused the needle. I don't think anybody does it in today's world. And then forgotten needle and forgotten patient. This happens in the present scenario. We are all to paraphrase another person, we are not Homo sapiens anymore. We are WhatsAppians. So what tends to happen is you have inserted the needle to the patient, and this usually happens. I have seen in many of the student therapists. No offense, but because student therapists are not directly responsible. Like if I have a student under me, then his mistake is my responsibility. So I have had students who were messaging me in WhatsApp, and when I said, "What are you doing?" the student says that I am giving ultrasound to my patient. So one hand goes into ultrasound and another hand into messaging. So that is multitasking that happens. So in those scenarios, what tends to happen? The patient. Sometimes you are treating 2-3 patients in 2-3 cubicles. You have inserted the needle to the patient, and the patient takes some time to show response to the needle. So you have gone to another cubicle to treat another patient, maybe fix up some machine or something. That's what happens in real life scenario, and then you completely started to chat or do WhatsApp. So that is forgotten patient. What happens with forgotten needle? You have put the patient into, say, side-lying position. You have put a few needles on the patient's gluteal area, maybe piriformis and medius or something. And then you have come to front and you have probably inserted a couple of needle in the knee, around knee as well. And now once you have removed the patient's needle, you must have removed, when I say you, please don't get offended, but this usually happens. Once the therapist removes the needles, the therapist kind of forgets the needle which is there in the patient's gluteal area. And the needle are removed, and you ask the patient to get up. The patient gets up, and the patient tries to sit, and then the patient gets a poke in the area in the manner he should not be poked. Jokes apart, forgotten needle is a real case. So it is best if you insert multiple needles, more than 3-4, to a patient in different areas, keep the guide tube on side, or count the needle in, count the needle out. If you have put 5 needles on the patient's body, when you remove, count 1, 2, 3, 4, 5. Because these problems do not happen every day. These problems happen once in a lifetime. So if you have a clear ethics or a roadway algorithm to practice, then these problems will never come. Then the minor adverse effects are needling pain that might have meant that you have over needled, also mean sometimes that the patient is deficient on vitamin C. Aggravation of symptoms, definitely over needling or over enthusiastic needling. Faintness, drowsiness. In your life, if you regularly needle, you'll get certain patients who get faint or drowsy, which is because of vasovagal attack. We understand what is vasovagal, right? Sudden activation of the parasympathetic nervous system, the vagus, which reduces, kind of seizes the heartbeat for some time. The brain does not get blood, so the person faints. That is our nature's own way to reduce the amount of load on the myocardium so that the flow of the blood doesn't have to go against the gravity, so the patient falls down. The person who gets vasovagal falls down, and then after some time, we also know what is vagal escape. The ventricular contraction restores, and the person kind of comes back. So whole thing takes an average of 5 to 10 minutes only. And the patient, although the patient faints per se, the patient is not into complete unconsciousness, so you can somehow communicate with the patient. So that is why screening the patient is very important. If you are screening the patient, you know the patient does not have any other pathology. Otherwise, if your patient has a history of epilepsy or any other kind of unconsciousness in the previous history, you will be uh, you will be tensed whether what kind of like unconsciousness it is. If it is only vasovagal, within 10 minutes the patient will be fit and fine. Now, certain precautions you need to do. Again, as I said, needling the trapezius or needling any other postural muscles should only be done in complete relaxation in supine line. Especially if you're needling the patient for the first time, the patient is excited and insertion of the needle, sudden change of excitation to relaxation, sympathetic to parasympathetic, adrenaline to vagus, the patient gets fainted. And again, this does not happen every day. 1 in 100, 1 in 1,000 of the cases, but you should be careful so that you can stop this happening with 100% certainty. So for all these purposes, to take care of all these issues, I had come up with a dry needling assessment form, which I had discussed a little bit, showed a glimpse of it yesterday. Today also I'll show the glimpse of it only. On the last day we'll discuss how to use this form, and in the study material of the last day I'll give you how to download a download link for this PDF of this form. And then, to streamline, to avoid the dangers, to safely and effectively needle, I have come up with this acronym called SPIDER: surface anatomy, position of the patient, incidence angle, depth of the target tissue, educating the patient, recording the session. Are those 6 steps, are those 6 areas. If you can do step by step with care, then you will be needling with the web of safety. So finally, I'll leave you with this particular quotation from Puker and Grunmeyer, who had done this study in 2001. You can again go back to net, go into go into Google Scholar, and you can refer their paper, fabulous stuff related to needle safety. They say that rare but serious traumatic complications could be avoided if practitioners had better anatomical knowledge or applied their existing anatomical knowledge in a better way. So that should be what we should be doing. We should be upgrading our anatomy, and then we should be using our anatomy knowledge into the patient's body when we are needling. If you can do that, then the risks related to dry needling is very less. Now I'll look into the discussions if something has happened. and then if there is any question in the chat box, I would be happy to discuss. Right, so as I can see, what will be done in case of broken needle stuck in muscle. So when you insert the needle, where does the needle break? The needle breaks. Say if you say that this is a needle, the black part is the handle, this is the shaft of the needle, this is the handle shaft junction. Then if you have inserted the needle all the way till the handle, if the needle at all breaks, the maximum chance of breaking is in the junction. So what you need to do is keep about a couple of millimeters above the skin, above the surface, this needle, the black part, the handle, so that if it breaks here, you still have enough purchase, enough space to put a forceps and pull it back. But suppose if the needle has broken in between, I have not seen this in dry needling needle or acupuncture needle, but what I have seen is in injection needle, in OPD, in surgical OPD. So ultimately, what does the physician do is take a scalpel, give a slit, use a forceps and pull it out. That is the only way. Video demonstration, that was not the purpose of these classes. Physiological mechanisms of DN, yes, Parvati will discuss them tomorrow, day after, and the next day. What will be the depth of the needle insertion so that it doesn't injure the nerve? For him, it will depend upon the nerve we are talking about. It will also depend upon the person's body structure. Now, if the body structures are to be, see, the human body was designed with a lot of intelligence. All the higher animals for that. The nature has taken its time to perfect the body so that all the vulnerable structures are kept very close to the midline, kept very protected. So your most important organs, the heart or brain, they are very protected. As you can see, the brain is in a closed box with two layers of bone. The heart has mediastinum, then it has lungs. The spinal cord has multiple layers of protection. Similarly, the nerves, your question was the nerves. Nerves are also very close to bone. So when you're inserting a needle, one of the thumb rule can be to stay close, to stay away from the midline, and to stay away from the nerve. Whether you're talking about radial nerve or whether you're talking about, say, the common peroneal nerve, stay away from the bone in general as a thumb rule, and you should be safe. But again, that is why it is very important for you and me to understand the surface anatomy. Okay, some more questions went back. 5 more minutes and I'll finish it. I don't want to keep it above 1 hour. Does wet needling practiced in India? If I'm correct, this is Rizwan. Rizwan, wet needle is injection. So as I was saying yesterday, if you have taken a shot of COVID vaccine, you have taken a wet needle. If not, whatever injection you have taken is wet needle. There is no actual term called wet needle. We want to differentiate dry needling for injection. That's why we call it as dry needle. If pacemaker was implanted to the patient, can we do dry needling? Yes, probably want to take the surgeon's consent and don't want to needle in case of any implant. You don't want to insert or needle in such an area where the needle touches that implant. How severe a pneumothorax can be. A pneumothorax can be asymptomatic issue, or a pneumothorax can produce death, which is a little unrealistic scenario in dry needling. But yes, there are documented evidence of needle-induced death. When any of the nerve is injured by needle, what will happen? Either the nerve will recover completely, or the nerve will recover partially, or the nerve will not recover in certain cases. I had shown a slide, right, one study where the radial nerve the person was having irreversible wrist drop. Can we use dry needling during muscular hypertrophy? You mean atrophy? Yes, you can. Again, it will depend upon what is the purpose of your needle. The insertion of the needle itself does not cure atrophy. How to identify trigger point? The trigger point has specific hallmarks of identification, you compress that area, the patient gets number one, pain in the referred area. So in its typical referral pattern is what the classic trigger point proponents say. According to your assessment form, can you please explain how joint replacement, pacemaker, metal implant conditions are contraindications and whether they are generally contraindicated? Uh, Hi Sadhana, long time. Yes, we'll discuss the assessment in the last day when we talk about standardization. And then one question. Ruxana is asking, when any of the nerves injured by needle, then what will happen to the patient? What do you think the patient will respond to? But don't get overtly scared about the nerve injury. You understand that every nerve follows more or less its course. So look at the surface anatomy, look at the surface marking of the nerve, and you are more or less safe. Iatrogenic pneumothorax, Soumya, iatrogenic means doctor produced. So if, for example, if I have a problem and I go to hospital, and then because of that I am getting another disease, then it will be called as iatrogenic. This is basic microbiology. Fever is a contraindication or not, how much of the fever the patient is having, why the patient is having fever, would be something to consider. As such, a low grade fever will not be considered a contraindication. Any effect on DOMS? If Yuntauma is to be believed, then dry needling of a certain kind can prevent DOMS. Will needling not increase the inflammation? Fantastic. Yes, we are going to discuss this when we talk about needle manipulation. Can we give Parkinson patient how have pain? Okay, a Parkinson patient has pain. Can you needle the patient with dry needling? Yes, you can. But again, if the patient is having pain because of his primary condition, the stiffness, poor posture, and everything, then you are treating the patient probably temporarily. You are not correcting the root cause. But if the patient has some kind of say contracture, tightness, and dry needling is one of your way to manage that, then why not? It's 3 o'clock now. I will stop. If there is any more question, can you please ask me via WhatsApp? You are all in the WhatsApp group and you can contact me via WhatsApp. Thank you so much. See you tomorrow again.